Welcome to Case-Based Medical Microbiology Tutorials. Let us start today's case. A young girl presents to emergency department with excruciating muscle spasms, a face squall, a stiff arched back, and clasp palm. She has also had difficulty swallowing and a stiff jaw. Her parents told that she had injury by a nail in the field last week. So, what could be the possible diagnosis? What are the likely causative agent or agents? And what is the pathogenesis, clinical features? What are the investigations, treatment, and prevention that we would like to do in this case? So let us start. So as you have guessed it right, it is a rigid spasmodic condition caused by an infection known as tetanus, and the causative agent is Clostridium tetani. So this is basically a gram-positive bacilli which has spores. And what is the pathogenesis? The source is that these spores they survive in soil and feces for years. They are very resistant structure. So let us understand its pathogenesis. So these spores they enter through skin injuries. It could be abrasions, it could be puncture wound or road traffic accident wounds or any kind of septic surgeries, unclean delivery of neonate or otitis media. So these spores, they can also enter through umbilical cord, which is infected of neonate, and when mother is not vaccinated. So that is the most common cause of neonatal tetanus as well. Now, what are the risk factors? Risk factors is basically that developing countries have higher incidence because of they have a soil which is rich in spores, especially in rural areas. They have warm and moist climate which is suitable for bacterial growth, and unhygienic surgeries and deliveries will provide easy transmission of infection. However, in India, we have reduced the incidence due to widespread vaccination programs. Now, let us understand its pathogenesis in detail. So, when the spores enter through wound, they germinate, they release a toxin, two toxin. One is trypnolysin, which is basically a hemolysin, but it has no role in pathogenesis. But the second toxin, that is trypnospasmin, which is the main toxin, and it is the plasmid-coated toxin, and that is the main pathogenic or virulent mechanism. This toxin, trypnospasmin, it travels retrogradely on axons of peripheral motor neurons and via circulation also. It blocks the release of inhibitory neurotransmitter, that is GABA and glycine, from the rancho cell interneurons of spinal cord. Now, if you can recall your physiology, these are the neurons which are playing role in presynaptic inhibition. So what we are doing here with help of this trypnospasmin is we are blocking that inhibition. So basically we are inhibiting the inhibition. So that will result in hyperexcitation of motor neurons and ultimately spastic paralysis. So there will be sustained muscle contraction, which is known as tetanus, and it can progress from head to trunk, that means in descending manner to extremities. The order is governed by length of the neurons. The first muscle, which is the most sensitive, is the masseter muscle, which results in lockjaw. It is also known as trismus, and it is the first symptom. However, if it is neonatal tetanus, then the feeding difficulty is the first symptom. Then facial muscles they go into spasm and it produces a grinning like face, which is known as rhisis sardonicus. Then the spasm of limb, affected limb, but hands and feet are usually spared, and generalized descending spastic paralysis will happen, especially of back muscle and extensors. Body will go into arc-shape extension, which is known as opisthotonus. All the deep tendon reflexes they are exaggerated, and if patient survives, then autonomic disturbances in second week of severe tetanus, manifesting as high or low blood pressure, tachycardia, inhibition of peristalsis of intestine, sweating, increased secretion in trachea, as well as acute renal failure. So, very severe condition. If not intervened immediately, it can end up in what you call as death or very severe complication. However, interesting thing to note is that mentation is normal in tetanus, and there is a variety of tetanus which is known as neonatal tetanus, which affects the neonate. It is defined as WHO that inability to suck and cry between day 3 and day 28 of life, along with rigid spasm in a neonate, is known as neonatal tetanus. It is also known as 8 disease because symptom starts after 7 days of birth, because that is the period which is known as incubation period, which takes time to develop the disease. Source of infection is usually unhygienic practices either during delivery, that is infected umbilical cord or cow dung application of umbilical cord, or there are not proper aseptic precautions taken during the delivery, or rarely also due to the circumcision or ear piercing can also result in neonatal tetanus. The peak incidence has been seen during July to September month. What are the complications too? We have already discussed is rhitis sardonychus and opisthotonus, but if respiratory muscle goes into spasm or laryngeal muscle goes into spasm, then it can result into asphyxia and airway obstruction and creates a medical emergency. What are the investigations? Usually, tetanus is a clinical diagnosis. So, lab investigations are only supportive to confirm your clinical diagnosis. You should start treatment based on your clinical diagnosis only, just like gas gangrene or diphtheria. Now, tissue from depth of wound, not swab. Wound swabs are not recommended. If you want to send it for culture, you should send tissues from the depth of the wound. And microscopy will show you gram-positive rod-shaped, large, bulging terminal round spore-bearing bacilli, which is known as drumstick appearance. And these are motile bacteria. But other Clostridium like Clostridium titanomorphum and sphenoids also have similar morphology. So microscopy is non-specific. It requires anaerobic culture using RCM, that is Robertson Cook meat growth enrichment culture, in which this bacteria is proteolytic in nature and it will turn the meat of the Robertson Cook meat medium black in color with foul odor. Uh, then subculture can be done on polymyxin B containing blood agar at 37 degrees centigrade. It will show swarming growth. There will be a film of growth. You will not find a single colony. So that is known as swarming. And these are the characteristic of microscopy and culture. Toxigenicity testing should be done from serum or urine specimen, and it is done using in vivo mouse inoculation test. But most of the time, tetanus is a clinical diagnosis, and we directly jump to the treatment based on the clinical diagnosis. So, what could be the treatment? First of all, isolate the patient in a separate room because any even minor stimulus can aggravate the spasm, even light also. If airway is compromised, if airway obstruction is there, then first protect the airway. Do endotracheal intubation or early tracheostomy, whatever is needed. Now, the disease is mediated by toxin. So, what is your first response to counter it? Obviously, antitoxin. So, that's why antitoxin is the mainstay of treatment, which is known as passive immunization. Antitoxin is nothing, it is the specific immunoglobulin against the tetanospasmin. So, in one arm, we will give single intramuscular dose of 250 international unit of human anti-tetanospasmin immunoglobulin, and it will provide us 30 days protection. If that is not available, you can even choose an equine, that is horse derived anti-tetanus serum, but you have to give 1500 international unit, but it will provide you only a short lasting protection of 7 to 10 days. And also the equine ATS is also associated with serum sickness and anaphylaxis risk. That's why we prefer human tetanus immunoglobulin. Tetanus toxoid vaccination, first dose should be given in another arm. If you have given STIG on right arm, then given tetanus vaccine on the left arm. If person is unvaccinated, and once recovery has been obtained, then you should complete the course as per the schedule. Now, someone will argue that okay, disease has already happened, infection has already happened, it will confirm the immunity. But in case of tetanus, that is not the case. Clinical tetanus does not provide immunity, and that's why we recommend the complete to complete the vaccination if person is not been vaccinated after the recovery. Uh, so obviously antitoxin is the mainstay of treatment. It will neutralize the already circulating toxin, but antibiotics cannot do that. Antibiotics cannot neutralize already released toxin, but they can prevent further release of toxin. And drug of choice here is IV metronidazole. Alternative is penicillin, and it should be given intravenously for 7 to 10 days. If the antibiotic is given within early stage of infection, that is within 6 hours, then yes, they can prevent the tetanus or at least reduce its severity before, because expression of toxin requires at least 6 hours. Other supportive treatment are needed because person is in rigid spasm. You should give antispasmodic like diazepam, which is a GABA agonist. You should give beta blockers like labetalol or morphine to control the sympathetic hyperactivity, which is seen in tetanus. Wound care and source removal is also essential. We have to clean the entry wound and debride any necrotic material, which could be the focus of infection, so that the further aggravation does not happen. So these are the important points in case of treatment of tetanus. Now let us move to the prevention. So in prevention, we will divide it into pre-exposure and post-exposure prophylaxis. And obviously, pre-exposure tetanus vaccination is the most effective measure, and it has been seen that this vaccine is basically a toxoid. It is made up from tetanus toxoid and removing the pathogenic component but keeping the immunogenic one, and it will generate immunity against this toxin, and this protective titer is 0.01 international unit per ml or more is protective. It is to be given intramuscularly and anterolateral part of thigh in children and deltoid muscle in adults. Now there are various formulation available. It could be monovalent tetanus toxoid or it could be combined vaccine like DTAP, as we have seen earlier in the case of diphtheria, that is pediatric dose diphtheria toxoid 25 Lafleur units along with tetanus toxoid and acellular pertussis component. Or it could be TD vaccine, that is tetanus toxoid along with adult dose of diphtheria toxoid, that is 2 Lafleur unit. Or it could be TDAP vaccine in some countries, for example, tetanus toxoid, adult dose diphtheria toxoid along with acellular pertussis component. Or it could be pentavalent vaccine along with DTPU combined hepatitis B and Haemophilus influenza B component. So in India, we are using pentavalent, DTAP and TD vaccine in schedule. So we have also discussed earlier the schedule in case of diphtheria, but again we are repeating. So children primary vaccine 7 doses are required. WHO, however, recommend only 6 doses. So pentavalent vaccine 3 doses at 6, 10, and 14 weeks, which is very similar to WHO's recommendation. But the DTAP booster, 2 doses, one at 16 to 24 months and one at 5 years, are also in alignment with WHO recommendation. But the TD vaccine booster, 2 doses, one at 10 years and 16 years, which is applied in India. However, WHO recommend only 1 dose between 9 to 15 years. So, as per WHO, only 6 doses are required, but in India, we are giving total 7 doses of vaccination. And it is also recommended by WHO that at least 4 years gap should be there between two booster doses. So that is about children primary vaccination. If it is adult, that is more than 18 years of age, then we should give TD vaccine. And those who have completed the primary schedule as mentioned above, then you can give booster every 10 years till 65 years. And if you have not completed the primary vaccination, then you should give 3 doses at 0, 1 month and 1 year, and then follow booster as per every 10-year recommendation. In India, to prevent neonatal tetanus, we also give 2 additional TD vaccine doses 4 weeks apart between 27 to 36 weeks of pregnancy. So that brings me to the pre-exposure prevention of neonatal tetanus. So apart from these 2 doses which are given in pregnancy, we also promote hospital or attendant deliveries, which focuses mainly on clean practices. There are 7 cleans which are applied during the hygienic delivery, that is clean hands of worker or attendant, clean surfaces, clean plate to cut cord, clean cord tie, clean cord stump, clean towel, and clean water. And India has achieved neonatal tetanus elimination status in 2016 by WHO. What does that mean? That means that neonatal tetanus rate in India in every district is less than 1 per thousand live birth. And that is a great achievement, and we have achieved this by more than 90% of vaccination coverage during pregnancy and more than 75% of attendant deliveries among the total. So that brings to the next phase, that is the post-exposure prophylaxis after injury or wound. Now, there are various guidelines regarding this. I have seen that UK guidelines are different, US guidelines are slightly different. So I have tried to simplify it so that there could be a consensus among all of us that this should be done. First of all, wound cleaning is required because after any injury or wound, obviously we thought that it could be a risk to tetanus. So first of all, if a wound is not clean, clean the wound. If you find any necrotic tissue, just remove it. Okay. Now the second step is whether to give vaccine or immunoglobulin, or that means to immunize person. That will depend on 2 things. One is vaccination status of person, and second, what is the wound type. Now, if we see this table, that on this side vertically, I have mentioned that what is the vaccination status. That means what are the previous doses of tetanus toxoid. That means incomplete or unknown status. That means less than 3 doses or unknown or not vaccinated, for example. And more than 3 or 3 doses, that means complete vaccination status. Now here we see clean wound and all other wounds. That means clean and minor wound are there, and rest of all the wounds you put in other category. So in clean and minor wound, yes, you require tetanus vaccine in case of less than 3 doses or unknown status. But if more than 3 doses are already given, that means person has completed its vaccination schedule, then you should see when was the last dose given. If it was given more than 10 years ago, then and then you require tetanus vaccination. Otherwise, you do not require tetanus vaccine single dose. Immunoglobulin has no role in clean and minor wound. Now coming to the all other wounds, yes, we require tetanus vaccine single dose in case of less than 3 doses or unknown doses, and then we will complete the rest of the schedule. Suppose he has taken 2 doses, then we have to give whatever the remaining doses are there. If that person is having more than 3 doses and last dose was more than 5 years ago, then you should give the vaccine in that person. And immunoglobulin is only required for less than 3 doses or unknown vaccination status. Now, one thing I would highlight here that if person is immunocompromised, severe immunodeficiency or AIDS is there, and there is not clean wound, then he should receive immunoglobulin regardless of its vaccination status. That is very important. So that finishes today's case. I hope you like the video. If you have any comment regarding recommendations or guidelines that you want to include me, do tell me in the comments. Like the video, share the video. Happy learning. You can buy the book on Amazon and Flipkart as well. Bye bye.